Okay, let's unpack this. You've handed us a stack of sources, and we're about to take a seriously deep dive into one of the most incredible organs in your body, the skin. Forget everything you thought you knew about it just being, a simple covering. Our mission today is to really get into these sources, understand the key players, the surprising functions, how things go wrong, and, frankly, master this information like the elite professionals who study it.
That's the goal.
Get ready for some aha moments as we peel back the layers of knowledge.
Absolutely. And it's important because historically the skin was often dismissed as just, well, a mechanical barrier. Pretty simple, right?
Yeah, just kind of there.
But these sources show us the modern understanding is revolutionary. It's massive, complex, and incredibly active, truly a vibrant organ.
It's doing so much more than just holding you together.
Yeah.
It's your first line of defense, obviously, against everything from physical bumps to microscopic invaders.
The obvious role, yeah.
But it's also a sophisticated sensory organ.
Yeah.
Think about all the different ways your skin feels the world. Touch, temperature, itch.
Incredibly sensitive.
And here's a cool one. It plays an endocrine role. That sun exposure you get. It helps power vitamin D synthesis right there in your skin.
Right in the skin. It's amazing. And it accomplishes all of this through a remarkable cast of cellular and structural components all working together. If you look at figure 25.1 in your sources, you see this intricate web.
Okay, let's break down those components. You've got the squamous epithelial cells, the keratinocytes. These are the workhorses for the physical barrier.
Exactly. They're held together super tightly by structures called desmosomes. Think of them as little spot welds.
Like cellular Velcro.
Kinda, yeah. And they're packed with tough protein called keratin. But they're not just passive bricks. They're also involved in immune responses, sending out signals like cytokines and defensins when trouble brews.
So they're active participants.
Very much so. Right in there with them are the melanocytes, producers of melanin, that pigment that gives our skin color and absorbs UV radiation to protect us. Vital protection.
And the immune system has key players living in the skin, like the dendritic cells, the Langerhans cells up top in the epidermis, and others deeper down.
The skin's resident immune surveillance.
They're like the skin's early warning system, aren't they?
Yeah.
They capture invaders, process them.
And then travel to the lymph nodes to show them to the T cells, basically teaching the adaptive immune system what to attack, mobilizing the cavalry.
Wow. And other immune cells like T and B lymphocytes, specifically home to the skin too.
Exactly. Certain T cells, directed by chemical signals from keratinocytes, are crucial for mediating inflammation in skin diseases. B cells are also part of the local immune response, making antibodies right there.
We even have a skin microbiome. Just like the gut, there's a whole ecosystem of bacteria living on your skin.
It's a huge field now. These guys are mostly helpful preventing harmful organisms from setting up shop and even helping to train the local immune system. It's a protective shield on a microscopic level.
Like having friendly soldiers guarding the walls.
A good analogy. Don't forget the nervous system intertwined throughout the skin nerve fibers that sense touch, pain, temperature, itch, and those that control sweat glands and tiny muscles attached to hairs.
Little grumps.
Exactly. And they can even influence the immune cells we just mentioned. It's all connected. And there are these intriguing Merkel cells down in the basal layer, still a bit mysterious, maybe involved in sensation or hormone signaling. Research is ongoing there.
Plus all the other bits we associate with skin. Sweat glands for cooling you down. Hair follicles that produce hair, but also hold stem cells ready to repair damage.
Really important for wound healing.
And sebaceous glands making oil, which we'll talk about more later, I'm sure.
They will. So when this incredibly complex system is disrupted maybe by sun, injury, inflammation, or something internal, you see a huge range of conditions. Wrinkles, hair loss, blisters, rashes, cancers, immune disorders. The list is long.
Long-term sun, for example, you mentioned UV protection, but too much.
Too much doesn't just age skin prematurely. It can blunt the skin's immune response and, critically, lead to DNA damage that causes neoplasms or cancers.
And sometimes what you see on the skin isn't just a skin problem, right? It's a clue to something else going on.
Absolutely. Drugs you take or systemic diseases like diabetes, amyloidosis, or lupus can cause skin manifestations. The skin is really a window into overall health.
Given how common skin conditions are, affecting millions, and how accessible the skin is to visual inspection, it's a vital diagnostic tool.
Definitely. The appearance and distribution of lesions provide crucial clues to what's happening underneath. And understanding this requires learning the specific language used in dermatopathology, terms like acanthosis or spongiosis that describe microscopic changes you see in biopsies. It's a whole vocabulary.
Okay, let's really focus now on how pigment works and the cells that make it melanocytes. Changes in skin color aren't just cosmetic. They can tell you about vulnerability to sun or signal underlying issues in the skin or even elsewhere in the body.
Very true. We'll start with the simplest. The freckle, or epithelius, as it's technically known. These are super common in light-skinned kids after sun exposure.
Little spots that pop up in summer.
Exactly. They're small, just a few millimeters, tan red or light brown spots. When you look closely, the color is due to increased melanin in the basal keratinocytes, the surface cells. The melanocytes themselves are there, maybe slightly bigger, but their number is normal.
So it's the amount of pigment in the surrounding cells, not more pigment cells.
Precisely. And what's interesting about freckles is they get darker with sun exposure and lighter in winter because the amount of pigment changes. They're also distinct from something like a café au lait spot, which is a larger, persistent birthmark not dependent on sun, and can be a sign of neurofibromatosis. Different mechanism.
Okay, contrast that with a lentigo. How's that different?
A lentigo is different because it's a benign increase in the number of melanocytes, not just the amount of pigment in the keratinocytes. They can appear at any age, even infants, not necessarily linked to sun exposure.
And visually, how do they look?
Still small, maybe 5-10 millimeter oval tan brown macules or patches. They can even be on mucous membranes, which freckles usually aren't.
Okay, and under the microscope?
Histologically, the key is you see more melanocytes lining up along the basement membrane in a linear, non-clustered pattern. They're actually more numerous. Crucially, they do not darken with sun exposure like freckles do. That presence of more melanocytes is the fundamental difference.
Got it. More cells, stable color. All right, time for the ubiquitous mole, the melanocytic nevus. Those people have several. These are common benign neoplasms.
And the sources tell us why they're true neoplasms. They have acquired genetic mutations. Often it's an activation in a cell signaling pathway called the RAS pathway, specifically mutations in genes like RAS or BRAF.
Okay, hang on. BRAF, that's a big-time cancer driver, isn't it? But here's the million-dollar question. Why don't these moles just turn into melanoma left and right?
Right. It seems like they should. This is where the body has a clever protective mechanism called oncogene-induced senescence. When those RAS or BRAF genes get activated in a mole cell, they start to proliferate a little, but then they hit a hard stop, like boom. They go into a permanent state of growth arrest.
A built-in break.
Exactly. This shutdown is enforced by a protein called P16INK4A. Think of P16 as a crucial brake pedal on cell division, inhibiting key proteins like CDK4 and CDK6. In melanoma, that brake pedal is often broken or bypassed.
Wow, that's a critical insight. The mole has the start of a cancer mutation, but the body puts a permanent stop sign up. Okay, visually, common acquired nevi are usually small, under 6 millimeter, uniformly colored, with smooth, round borders.
Pretty unremarkable, usually. You might notice they get a bit more prominent during pregnancy. They can be sensitive to hormones.
And they evolve over time, right? They don't stay the same forever.
Correct. They often start as flat, junctional nevi with nests of melanocytes right at that dermo-epidermal junction. These cells look quite uniform and calm under the microscope.
Then what happens?
Then they can grow downwards into the dermis, becoming compound nevi, which are often more raised. In really old moles, all the nests might be down in the dermis, becoming intradermal nevi, often losing their pigment too.
And there's something called maturation.
Yes, a key feature helping pathologists distinguish benign moles from melanoma is maturation or neurotization as you go deeper. The cells closer to the surface are bigger and pigmented, growing in nests. But as you go deeper, they get smaller, lose pigment, appear in cords or as single cells, and can even start to look like nerve tissue cells, hence neurotization.
So they change as they go deeper.
Right. This change, this maturation, is characteristic of benign moles. Melanoma cells don't do that. They tend to look aggressive and uniform all the way down. No maturation.
Understanding that progression is key to recognizing when something might be different. And speaking of different, that brings us to dysplastic nevi. These sound important.
They are crucial because they aren't just markers of risk for melanoma, they can be direct precursors.
So they can actually turn into melanoma.
The evidence is strongest in families with dysplastic nevus syndrome. This is an inherited condition where people get lots and lots of these atypical moles, and their risk of developing melanoma is very high, over 50% by age 60, often getting melanomas in multiple places. We've actually seen these moles transform into melanoma under the microscope in those cases.
Okay, but what about for most people, if you just have one or two?
Yeah, that's important. Most dysplastic nevas, even if you have one or two, don't turn into melanoma. They signal increased risk, especially if you have many, but an isolated one has a very low chance of transforming on its own. They're more like a warning flag.
So how do they get around that stop sign, that senescence break we talked about with regular moles?
Good question. While they often have the same RAS-BRAF mutations as regular moles in dysplastic nevus syndrome, there are often inherited mutations in the gene that makes that P16 protein the brake pedal itself, or mutations that make the cell cycle machinery resistant to P16. This lets them escape senescence. Other genetic changes likely play a role too. It's probably a multi-step process.
So the break is faulty from the start or less effective? How do they look different?
Visually, dysplastic nevi are often larger than common moles, maybe over 5 millimeter. In the syndrome, you can have hundreds. They can be flat, slightly bumpy, pebbly, or even look like a target with a darker center. They're recognized by their size, varied color, variegation, and irregular borders, not smooth and round.
Kind of messy looking compared to a regular mole.
Exactly. And unlike common moles that mainly show up on sun-exposed skin, dysplastic nevi can appear anywhere, even in covered areas like the scalp or buttocks.
And microscopically, more chaos.
Pretty much. They're atypical in structure and cell appearance. The nests of cells are enlarged and confused together. You also see single, atypical melanocytes spreading along the basal layer in a way they shouldn't, lentiginous hyperplasia. The cells themselves have enlarged, often weirdly shaped, dark nuclei, hyperchromasia.
And the surrounding tissue.
They also have some telltale changes in the dermis underneath. Some inflammatory cells, lymphocytes, pigment that's dropped into the dermis and picked up by cleanup cells, macrophages. That's called melanin incontinence and sometimes linear fibrosis around the reet ridges. The diagnosis isn't based on one feature, but on a constellation of these atypical features.
Right. It builds a picture.
Yeah.
All of this leads us to the main event, melanoma. It's the most dangerous skin cancer, but the good news is it's highly curable if caught early.
Hugely curable early on. Incidence is rising, which is concerning, but death rates are actually dropping, partly thanks to amazing new treatments we'll get to.
Skin is the most common site, obviously, but it can pop up in mucous membranes, even the eye. Our sources focus on the skin melanomas.
Yes, cutaneous melanomas. UV radiation from sun exposure is a major driver, causing specific types of DNA damage mutations, often with a UV signature. It's most common in light-skinned people, especially on sun-exposed areas. Genetics that lead to less melanin also increase risk.
But it's not totally straightforward, is it? The relationship with sun.
No, it's nuanced. Severe blistering sunburns, especially early in life, might be a bigger risk factor than just cumulative sun exposure over years. And melanomas do occur in darker skin and on areas that never see the sun, meaning other factors, maybe environmental exposures or different genetic pathways, are also at play. Sunlight isn't always essential.
Let's talk about the genetic changes that drive melanoma. You mentioned escaping the cell cycle breaks.
Right. Disrupting cell cycle control is crucial. That CDKN2A gene we mentioned, making P16 the brake, is mutated in about 40% of familial melanoma cases and commonly in sporadic ones. It's a complex gene making multiple proteins. Losing P16 function lets cells divide uncontrollably and escape senescence. Other parts of that G1 checkpoint can also be faulty.
And the growth signals. Always push and go.
Exactly. Aberrant increases in pro-growth signaling pathways, often involving RAS and PI3KK2, are very common. Mutations in BRAF are found in 40-50% of melanomas, RAS in 15-20%. BRAF mutations often go hand in hand with loss of another brake, PTN, which revs up PI3KK signaling even more.
So multiple hits amplifying growth.
Right. And interestingly, melanomas in non-sun exposed areas less often have BRAF mutations, but might have activating mutations in KIT, a gene upstream in the same pathway, or loss of NF1, another negative regulator of RAS.
And you mentioned immortality, telomerase.
Yes, for a cancer to become immortal, it needs to keep its chromosome ends, telomeres, intact. Normally, telomeres shorten with each division, limiting cell lifespan. Cancer cells often reactivate an enzyme called telomerase to rebuild the telomeres. Mutations in the TERT promoter, which controls the telomerase gene, are incredibly common in sporadic melanoma, about 70%, making it the most frequently mutated gene overall. This turns telomerase back on, essentially making the cells immortal and countering senescence.
Okay, so visually, what screams melanoma compared to a mole?
Often it's the appearance. They have striking color variations, not just shades of brown, but black, red, blue, even gray or white if they're regressing or losing pigment. The borders are a big clue, irregular, notched, not smooth and round like a benign mole usually is.
And there's this concept of growth phases, radial and vertical.
A critical concept for prognosis. Initially, melanoma cells might just spread horizontally within the epidermis, and maybe the very superficial dermis, the radial growth phase. Think of it spreading outwards like a stain. In this phase, they generally haven't gained the ability to metastasize. This includes types like lentigo maligna on the face of older people, or the common superficial spreading melanoma.
So relatively contained initially, but then.
But eventually, after a period that varies greatly, they can shift into the vertical growth phase. This is when they start invading downward into the deeper dermis as a distinct mass, often appearing clinically as a bump or nodule within the flatter lesion. This shift signals that the cells have acquired the potential to metastasize.
And they don't mature as they go down.
Correct. Unlike a benign mole, you don't see those cells change or mature or neurotize as they invade deeper. They stay looking aggressive.
And the cells themselves, what do they look like?
Melanoma cells themselves are typically larger than normal melanocytes or nevus cells. They have bigger nuclei with irregular shapes, clumped internal material, chromatin, and often prominent red spots inside the nucleus called nucleoli. They look atypical and angry, whether they're spreading horizontally or invading deeply.
Sometimes it's tricky for pathologists, though.
Yes, sometimes pathologists encounter histologic gray zones, atypical melanocytic lesions, where it's hard to definitively say if they're benign or malignant based on current criteria. These often require complete excision and very close follow-up.
Once a melanoma is excised, how do you figure out the prognosis?
The pathologist looks at several features. The most important is tumor depth, measured in millimeters, called Breslow thickness. How deep has it invaded? Other crucial factors include how many dividing cells they see, mitotic rate, if there's evidence the body's immune system is fighting it. Tumor-infiltrating lymphocytes, or TILs, more is generally better.
The body fighting back.
Right. Also, if the surface is broken or ulcerated, ulceration is bad. If there's evidence of regression, where some of the tumor seems to have been destroyed by the immune system, which paradoxically can sometimes be a worse sign if it obscures the true depth, and its location on the body. Thinner tumors, low mitotic rate, lots of TILs, and no ulceration usually mean a better outlook.
And lymph nodes.
Because melanoma often spreads to the nearest lymph nodes first, a sentinel lymph node biopsy is often done. Finding even microscopic melanoma cells in that first draining node indicates a worse prognosis, and the number of involved nodes correlates strongly with survival.
Okay, so for everyone listening, what are the clinical warning signs? The ABCDEs.
Yes, the ABCDEs are a helpful guide. Asymmetry, one half doesn't match the other. Irregular borders, scalloped or poorly defined. Variegated color, multiple shades of brown, black, red, blue, white. Increasing diameter, often larger than 6 millimeters, about the size of a pencil eraser, but can be smaller. And evolution, meaning any change in size, shape, color, elevation, or symptoms like bleeding or itching over time, especially rapid change.
Change is key.
Change is the most consistent warning sign. Most melanomas are caught when small and asymptomatic, but itching or pain can sometimes occur. Early recognition and excision are critical.
The genetic insights have really changed treatment, haven't they?
Dramatically. Targeted therapies that block those activated pathways like RASP3 categorising, especially BRAF inhibitors for melanomas with BRAF mutations, are now standard for advanced disease. Since metastatic melanoma is notoriously resistant to traditional chemo, these targeted drugs, often used in combination based on the tumor-specific molecular profile, are crucial.
And immunotherapy. That's been huge news.
Absolutely revolutionary. Melanoma is quite immunogenic, meaning the immune system can often recognize it as foreign. Immune checkpoint inhibitors basically take the brakes off the immune system, blocking proteins like CTLA4 and PD-1 that normally keep T cells in check, so it's unleashed to attack the tumor. Melanoma has been incredibly responsive to this approach, leading to long-lasting remissions in some patients with advanced disease.
Amazing progress.
It really is. The challenge now is balancing that powerful anti-tumor effect with potential autoimmune side effects, where the unleashed immune system attacks normal tissues. Optimizing treatment and managing toxicity is a major focus.
So the big picture for moles and melanoma. Common moles with BRAF mutations usually don't transform thanks to that senescence break.
Right, the break holds.
Dysplastic nevi signal increased risk, and some can be direct precursors, especially in familial syndromes where the break is faulty.
Markers and sometimes precursors, yeah.
Melanoma is aggressive, strongly linked to sun exposure, and its depth, Breslow thickness, is key for prognosis.
Depth is paramount.
And excitingly, its ability to trigger an immune response makes it targetable with these game-changing checkpoint therapies.
A real paradigm shift in treatment.
All right, let's shift gears to benign epithelial tumors. These are common growths that arise from the surface layer of the skin, the epidermis, or its related structures like hair follicles and glands.
Yeah, very common things you see on the skin. They often look just like miniature versions of the skin structures they come from, sort of recapitulating them.
They are usually harmless, but sometimes their appearance can be tricky, right? They might look like something worse.
Exactly. Especially if they're pigmented or inflamed, they can raise concern for malignancy, so a biopsy might be needed just to be sure. And here's where it gets really interesting. Occasionally, these benign tumors can be little signposts pointing to underlying syndromes associated with potentially life-threatening internal cancers.
Wow, so a skin bump could be a clue to something inside.
Precisely. Recognizing the skin tumor helps identify the syndrome and prompts doctors to start looking for those other cancers early. It can be incredibly important.
Let's take seborrheic keratosis. I think I've seen these. Super common.
Extremely common, especially in middle-aged and older folks. They just pop up spontaneously, often loads of them on the trunk, but also face, arms, and legs. There is a variant called dermatosis papilosa nigra, those small, dark bumps commonly seen on the face of people of color.
What causes them? Just aging.
Often sporadic, but genetically, these frequently have mutations that activate a growth signal receptor called FGFR3. And there's a clinical sign, the Lesser-Trella sign, where someone suddenly develops large numbers of these. That's considered a paraneoplastic phenomena, meaning it's triggered by an underlying internal cancer, often a GI carcinoma. The tumor might be pumping out growth factors like TGF-alpha that stimulate the skin cells.
Okay, so what do they look like?
Visually, they look like round, flat, waxy plaques sort of stuck on the skin, like a barnacle. They're usually tan to dark brown and have a velvety or slightly rough granular surface. A helpful trick. With a hand lens, you can often spot little keratin-filled pore-like openings, which helps distinguish them from something more concerning like melanoma.
And under the microscope?
They are sharply defined growths made of sheets of small cells resembling basal cells, what we call basiloid cells. They produce lots of keratin on the surface, hyperkeratosis, and you see characteristic small cysts within them, filled with keratin called horn cysts or invagination cysts. Very typical look.
Okay. Next up, acanthosis nigricans. This sounds like another warning sign.
It absolutely can be. This is an important cutaneous sign. It looks like thickened, dark, velvety skin, most often in body folds like the armpits, neck, or groin.
What does it warn you about?
There are two main types based on the cause. Over 80% are the benign type, often starting slowly in childhood or puberty. They can be inherited, or, much more commonly, linked to conditions like obesity or endocrine issues, especially type 2 diabetes. That's the most frequent association. Insulin resistance seems key.
And the other type?
The other type is malignant, associated with internal cancers, most often stomach cancer, gastric adenocarcinoma, usually appearing in middle-aged or older individuals. This is another paraneoplastic phenomenon. The cancer is producing substances that affect the skin growth.
So different causes, same look. What's the underlying mechanism?
The unifying feature in all forms seems to involve disturbed, increased signaling from growth factor receptors. In rare inherited forms, there are mutations in FGFR3. Just like with seborrheic keratosis, though the resulting skin appearance is different, it's unclear why. In type 2 diabetes, high insulin levels stimulate a different receptor, IGFR1. In the cancer-associated form, it might be growth factors like TGF-A activating yet another receptor, EGFR. So different pathways, similar skin outcome.
And the microscopic appearance.
The look under the microscope is pretty consistent regardless of the cause. The epidermis and the dermal papillae underneath get these sharp peaks and valleys, creating that velvety texture visually. The epidermis is thickened, hyperplasia, there's hyperkeratosis, and slight basal cell hyperpigmentation. But notably, there's no increase in melanocytes. The darkness comes from increased melanin in the basal keratinocytes, not more pigment cells.
Got it. Now, the fibroepithelial polyp, also known as an acrocordan, squamous papilloma, or simply a skin tag. Everyone knows these, right?
Oh yeah, one of the most common skin lesions out there. Seen commonly in middle-aged and older adults, typically on the neck, trunk, face, and in body folds like armpits or groin.
Are they linked to anything serious?
Mostly sporadic and harmless. Rarely they can be part of a syndrome like Burt-Hogg-Dubé, which involves other types of parafollicular tumors and kidney cancer risk, but usually they're just isolated tags.
What are they really?
They look like soft, fleshy, bag-like tumors hanging off the skin by a narrow stalk. Microscopically, it's just a core of fibrous tissue and blood vessels covered by normal-looking squamous epithelium. Very simple structure.
They cause problems.
They can get twisted on their stalk, which cuts off blood supply, torsion, and makes them painful, often prompting removal. Mostly they're just cosmetically annoying. They can be more numerous in people with diabetes or obesity, and definitely get more common and prominent during pregnancy, suggesting some hormonal influence.
Okay. Epithelial or follicular inclusion cysts, or WENS. Also very common.
Yep. Also very common. These are basically sacs formed when the epidermis or a hair follicle folds in on itself or gets blocked and expands, forming a cyst filled with keratin debris.
Can they get inflamed?
Oh yeah. If they get injured and rupture, they can spill that keratin, which is quite irritating, into the surrounding dermis. This causes a pretty significant and painful inflammatory reaction, a granulomatous response.
Right. Now, adnexal or appendage tumors. This sounds like a big category.
It is. There are literally hundreds of types described. These are neoplasms that show differentiation towards the skin appendages, sweat glands, endocrine or apocrine, hair follicles, or sebaceous glands. Their clinical importance varies a lot.
How so?
Well, some are totally benign but can be easily mistaken for skin cancers like basal cell carcinoma because they can look similar clinically or even share some microscopic features, but others are critical warning signs. If someone has multiple adnexal tumors, especially certain types, it can signal an inherited germline mutation in a tumor suppressor gene.
Like the signpost thing again?
Exactly. These seemingly trivial skin bumps are then clues to look for much more serious internal cancers associated with that particular syndrome. A key example is multiple trichoelomoma's benign hair follicle tumors, which can warn of Cowden syndrome. Cowden is linked to germline mutations in the PTN gene and carries an increased risk of breast, endometrial, thyroid, and other cancers. Recognizing the skin finding is crucial for screening.
That's vital information. What do these adnexal tumors generally look like?
Appearance-wise, they're often pretty nondescript flesh-colored solitary or multiple papules or nodules. Some have specific locations they prefer. Endocrine poroma from sweat ducts is typically on palms and soles where endocrine sweat glands are numerous.
What about others?
Cylindromas, which show sweat duct differentiation, often appear on the forehead or scalp. When multiple, they can merge together into a large hat-like growth, colorfully called a turban tumor. These can be inherited, autosomal dominant, and are associated with inactivating mutations in the CYLD gene, a tumor suppressor that normally helps regulate cell growth via NFKB. CYLD mutations are also seen in other related familial adnexal syndromes.
Okay. Any others commonly seen?
Syringomas, also with endocrine differentiation, are those multiple small tan papules often seen near the lower eyelids. Sebaceous adenomas, tumors of sebaceous glands, can be a sign of Muratori syndrome, which is associated with internal cancers, especially GI cancers, and is actually a variant of Lynch syndrome, hereditary non-polyposis colorectal carcinoma, which involves inherited defects in DNA mismatch repair genes.
So many connections.
It's fascinating. Pilomatricoma, differentiating towards the hair follicle matrix, the growth center, is often linked to activating mutations in a gene called CTNNB1, which encodes beta-catenin, a protein essential for normal hair development and growth, and tumors with apocrine differentiation usually pop up where apocrine glands are found, like the armpits and scalp.
Can you give us a flavor of how they appear microscopically?
Sure. A cylindroma shows islands of basiloid cells, small dark cells resembling basal cells that fit together tightly like jigsaw puzzle pieces, embedded in a pink fibrous dermal matrix, often with little duct structures inside the islands. Trochoepithelioma is a proliferation of similar basiloid cells, but they're trying to form primitive hair follicle-like structures.
And the sebaceous ones?
A sebaceous adenoma is a lobular growth of sebaceous cells. You see less mature basaloid cells on the outside of the lobules and more mature sebocytes with characteristic frothy or bubbly cytoplasm due to lipid vesicles towards the center. A pilomatrixoma has sheets of basaloid cells that abruptly transition into characteristic ghost cells, pale outlines of cells that look like they were hair matrix cells but have lost their nuclei. Apocrine carcinoma, a malignant one, shows ductal structures in a specific type of secretion called decapitation secretion, like normal apocrine glands. But importantly, it shows infiltrative growth into surrounding tissue.
So malignant versions exist too?
Oh yes. Malignant variants of most adnexal tumors exist, though many are rare. For endocrine tumors, the malignant forms actually seem more common than the benign ones. Sebaceous carcinoma, especially arising from the meibomian glands of the eyelid, can be quite aggressive and potentially metastasize. Malignant endocrine and apocrine carcinomas can sometimes be tricky to identify and might look very similar to metastatic adenocarcinoma from another organ, like the breast or lung, because they tend to form gland-like structures. Biopsy and sometimes special stains are key.
Now let's focus on tumors that come from the main layer of the skin, the epidermis itself, and range from premalignant to outright malignant, starting with actinic keratosis, or AK.
Right. AKs usually appear on skin that's been damaged by years and years of sun exposure, and they feel rough, like sandpaper, due to thickened surface keratin, hyperkeratosis. Very common in light-skinned individuals. Less commonly, ionizing radiation, industrial chemicals like hydrocarbons, or arsenic exposure can also cause them.
Why are they important?
They are clinically important because they are precancerous. They have the potential to progress over time into invasive cutaneous squamous cell carcinoma. Think of them as analogous to the dysplasia seen in the cervix before squamous carcinoma develops there. They represent atypia abnormal cell changes.
What do they look like?
Visually, they're often small, usually less than 1 centimeter, and can be tan, brown, red, or skin-colored. That rough sandpaper-like consistency is key. Sometimes, if there's a lot of excess keratin production, they can build up into a projection called a cutaneous horn, which can look quite dramatic. You see them most frequently on sun-exposed sites like the face, ears, scalp, especially if bald, arms, and the backs of hands. On the lips, it's called actinic cheilitis.
And under the microscope, what makes them precancerous?
Microscopically, the defining feature is cytologic atypia. The cells look abnormal primarily in the bottom layers of the epidermis. You might see too many basal cells, hyperplasia, or the basal layer can even be thinned, atrophy. These atypical basal cells often have pinker cytoplasm than normal due to abnormal keratin production, dyskeratosis. Crucially, you can still see the connections, intercellular bridges, between the cells, which helps distinguish them from basal cell carcinoma. The dermis underneath invariably shows changes from chronic sun damage thickened blue-gray elastic fibers, solar elastosis. The very top layer, the stratum corneum, is thickened and often retains cell nuclei, parakeratosis, which it normally shouldn't.
Can it get worse?
Yes. When the atypia progresses to involve the full thickness of the epidermis, it's then called squamous cell carcinoma in situ, a sentinel carcinoma that hasn't broken through the basement membrane yet.
What happens to AKs? Do they always turn cancerous?
No, not always. They have 3 potential outcomes. They can disappear spontaneously, regress, they can remain stable for years, or they can progress to invasive SCC. Because of that risk of transformation, which varies but is definitely present, local treatment is generally recommended. This can involve things like freezing them off, cryotherapy, scraping them, curettage, or using topical treatments like chemotherapy creams, for example, 5-fluorouracil, or immune-activating creams like imiquimod. Imiquimod, how does that work? It activates toll-like receptors, TLRs, on immune cells in the skin, basically stimulating the local innate immune system to recognize and destroy the abnormal precancerous cells. Quite clever.
This leads us naturally to squamous cell carcinoma, SCC itself. This is the second most common skin cancer.
That's right. Second only to basal cell carcinoma, usually found on sun-exposed sites in older people, and statistically more common in men overall, except perhaps on the lower legs in women.
Is it very dangerous?
Most are discovered when they're still small and can be removed surgically with high cure rates. The risk of them spreading, metastasizing to regional lymph nodes, is relatively low, generally less than 5%, and usually only occurs with larger, more deeply invasive lesions that have penetrated into the subcutaneous tissue, or those arising in specific settings like chronic wounds or immunosuppression.
What's the main cause? Still sun.
By far the most important cause is DNA damage induced by UV light exposure. The incidence is directly proportional to the cumulative amount of sun exposure someone has had over their lifetime.
Are there other major risk factors?
Yes. Another key association is immunosuppression, whether from chemotherapy, medications given after an organ transplant, or diseases like HIV. This weakens the body's immune surveillance that normally eliminates abnormal cells. Immunosuppression also seems to increase keratinocyte susceptibility to infection with certain types of HPV, specifically subtypes 5 and 8, and subsequent transformation. Yes, these specific HPV types, 5 and 8, are strongly implicated in a rare inherited condition called epidermodysplasia verruciformis, where individuals have widespread flat warts and a very high risk of developing multiple cutaneous SCCs, often in sun-exposed areas. It suggests a synergy between the virus and UV damage in some contexts.
Genetic genetically what's going wrong in SCC?
Acquired genetic defects accumulate in sporadic tumors and their precursors, the actinic keratoses. Mutations in the TP53 tumor suppressor gene are very common, often found even in AKs, particularly in Caucasians, suggesting that P53 dysfunction is an early event in sun-induced skin cancer development.
How does losing P53 contribute?
Normally, P53 responds to DNA damage, like that caused by UV, by halting the cell cycle to allow for repair or triggering cell death, apoptosis, if the damage is too severe. When P53 is lost or mutated, cells with damaged DNA can survive and divide, accumulating more errors. The TP53 mutations found in skin cancers often occur at specific spots, pyrimidine dimers, that are characteristic hotspots for UV-induced damage. People with inherited defects in DNA repair pathways, like xeroderma pigmentosum, have a dramatically increased susceptibility to SCC, highlighting the importance of repairing UV damage.
Are there other key mutations besides TP53?
Yes, it's usually a combination. Other commonly implicated pathways involve increased RAS signaling and decreased Notch signaling. Notch signaling is actually required for normal keratinocyte maturation, so losing it contributes to the abnormal proliferation and differentiation seen in SCC.
Visually, what does SCC look like? We talked about AKs.
SCC in situ, the non-invasive stage, typically appears as sharply defined red scaling plaques. Invasive SCC is usually more substantial, often a firm, raised nodule, sometimes dome-shaped, with variable amounts of keratin production on the surface, which might look like a thick hyperkeratotic scale or crust, and it may ulcerate as it grows.
And microscopically?
SCC in situ shows atypical nuclei involving all levels of the epidermis, from top to bottom, but still contained above the basement membrane. Invasive SCC shows nests and islands of malignant squamous cells that have broken through the basement membrane and invaded the underlying dermis. The degree of differentiation varies widely. Some tumors are well differentiated, forming keratin pearls and recognizable squamous cells, while others are poorly differentiated or anaplastic, looking very disorganized, making diagnoses potentially harder without special stains, like immunohistochemistry for keratins.
Okay, now for the most common one, basal cell carcinoma, BCC.
Yes, the most common invasive cancer worldwide, period. Not just skin cancer. It's a distinctive, locally aggressive cutaneous tumor strongly associated with mutations that activate the hedgehog signaling pathway.
Locally aggressive, but does it spread?
That's the key difference from many other cancers. BCCs are typically very slow growing and they rarely metastasize. Less than 0.5% become locally aggressive enough to be disfiguring or invade deep structures, and distant spread is extremely uncommon.
Where do you usually find them?
Predominantly on sun-exposed sites, especially the face and neck, and lightly pigmented elderly adults. Like SCC, the incidence is increased with immunosuppression and in individuals with inherited DNA repair disorders like xeroderma pigmentosum.
You mentioned the hedgehog pathway. Tell us about that link.
The major insight into its cause came from studying a rare inherited condition called nevoid basal cell carcinoma syndrome, also known as Gorlin syndrome. This is an autosomal dominant disorder where affected individuals develop multiple BCCs, often starting at a young age, before 20, along with other tumors and developmental abnormalities like jaw cysts and skeletal defects. These individuals have a germline loss-of-function mutation in one copy of the PTCH1 gene. PTCH1 is a receptor and a key negative regulator in the hedgehog signaling pathway. Then, they acquire a second hit inactivation of the remaining normal PTCH1 allele in their skin cells, often a mutation caused by UV damage, like a C to T transition, a classic UV signature.
How does the hedgehog pathway work normally?
Okay, simplified. PTCH normally acts like a brake on another protein called smoothing SMO. When the signaling molecule, sonic hedgehog, SHH, binds to PTCH, it releases this brake, allowing SMO to become active. Active SMO then leads to the activation of a transcription factor called GLI1, which turns on genes promoting cell growth and survival.
So in Gorlin syndrome?
In Gorlin syndrome, the PTCH brake is genetically broken due to the inherited mutation plus the second hit. This leads to constitutive, uncontrolled activation of SMO and downstream GLI1 signaling, driving the uncontrolled proliferation that results in BCC formation.
And this applies to regular BCCs too?
Absolutely. Mutations that activate the hedgehog pathway are prevalent in sporadic BCCs as well. Most commonly, it's loss-of-function mutations in PTCH, but sometimes activating mutations in SMO itself are found. Again, many of the PTCH mutations found in sporadic BCCs show the typical UV signature. This deep understanding of the pathway led directly to the development of targeted drugs, specifically SMO inhibitors, which can be very effective for treating advanced or metastatic BCC.
What do BCCs typically look like?
Classically, they present as pearly papules or nodules, often with prominent small dilated blood vessels visible on the surface, called telangiectasias. Some BCCs contain melanin pigment, which can make them look brown or black and potentially confusingly resemble nevi or melanomas.
Do they always stay as small bumps?
No, advanced lesions can ulcerate in the center, often developing a crusted surface with rolled borders. These can become quite large and locally invasive if neglected, destroying surrounding tissue, including cartilage and bone, hence the archaic term rodent ulcers. There's also a superficial variant of BCC that presents as a flat, erythematous, sometimes slightly scaly or pigmented plaque, which can sometimes resemble eczema or even early melanoma.
And the histology, how do they look different from SCC?
Microscopically, the tumor cells resemble the cells of the normal epidermal basal cell layer, hence the name basal cell carcinoma. They typically arise from the epidermis or sometimes hair follicles, but importantly, not for mucosal surfaces, which lack hair follicles. The growth pattern varies. Some are multifocal, spreading superficially from the epidermis. Others are nodular, growing downwards into the dermis as cords and islands of these basaloid cells.
What are the key microscopic features?
The tumor cells have relatively scant cytoplasm and dark hyperchromatic nuclei. The islands of tumor cells are often embedded in a mucinous matrix, and there's typically a surrounding reaction of fibroblasts and lymphocytes. A very characteristic feature is seen at the edge of the tumor nests. The peripheral tumor cells tend to arrange themselves radially with their nuclei aligned, a pattern called palisading. Another helpful diagnostic clue is that the surrounding stroma often retracts or pulls away from the tumor nest during tissue processing, creating artificial clefts or separation artifacts. This clefting helps differentiate BCC from some benign appendage tumors that can look similar otherwise.
Okay, let's summarize these key epidermal tumors. BCC and SCC incidence strongly correlated with lifetime sun exposure.
Definitely the major risk factor for both.
Cutaneous SCC can arise from precancerous actinic keratoses or from other causes like chemicals, chronic inflammation, or HPV, especially with immunosuppression.
Right, multiple potential origins.
And cutaneous SCC is generally less aggressive than SCC, arising in mucosal sites, but it still has potential for metastasis, especially if large or deep.
Lower risk than mucosal, but not zero risk, needs respect.
BCC is the most common human malignancy overall. Locally aggressive but driven by hedgehog pathway mutations, and metastasis is extremely rare.
Very rare spread, but can cause significant local damage if ignored. Now let's go a layer deeper and talk about tumors originating in the dermis, the layer of connective tissue under the epidermis. We'll look at two primary skin tumors here from the sources.
Okay, first, the benign fibrous histiocytoma, which you said is commonly known as a dermatofibroma.
That's right, dermatofibroma is the common name. These are benign dermal neoplasms, part of a heterogeneous family, and their exact cell lineage is still a bit debated. They're very common in adults, often seen on the legs, especially in young and middle-aged women. They usually present as firm, tan to brown papules, typically less than 1 centimeter.
Do they cause symptoms?
They're often asymptomatic, maybe a little tender, and patients might notice they change size slightly over time, sometimes dimpling inwards when squeezed. Their behavior is completely indolent, meaning benign.
What causes them? Just a reaction to something.
The exact cause remains a mystery for most. A history of minor trauma, like an insect bite, is sometimes reported, leading to the idea they might be an abnormal response to injury. However, the finding of specific fusion genes involving the ALK gene partner in a subset suggests that at least some are true neoplasms, not just reactive growths. Histologically, they seem to be composed partly of factor XIII positive dermal dendritic cells or related fibrohistiocytic cells.
And under the microscope.
When you look at it under the microscope, the most common form, dermatofibroma, shows a well-defined but non-encapsulated mass of spindle-shaped cells situated in the mid-dermis. These cells often entrap existing collagen bundles at the edge. The tumor can sometimes extend down into the subcutaneous fat. A peculiar and very characteristic feature is that the epidermis directly overlying the dermal tumor often shows hyperplasia. It gets thickened and sends down long, often hyperpigmented ridges. This is sometimes called pseudoepitheliomatous hyperplasia and can be a helpful diagnostic clue. There are several histologic variants described as well.
Okay, contrast that with dermatofibrosarcoma protuberans, or DFSP. This one sounds a bit more serious.
Well, it is. It's considered a well-differentiated primary fibrosarcoma of the skin. It's characterized by slow but persistent growth. It's locally aggressive, and it has a significant tendency to recur after surgical removal if margins aren't wide enough.
Does it spread?
Thankfully, it rarely metastasizes to distant sites. Metastasis is more common in tumors that show greater cytologic atypia or areas resembling conventional fibrosarcoma within them.
Is there a known genetic cause?
Yes, there's a very specific molecular hallmark. A characteristic translocation, usually involving chromosomes 17 and 22, which swaps parts between the collagen type I alpha 1, COL1A1 gene, and the platelet-derived growth factor beta, PDGFB gene. This fusion puts the PDGFB coding sequence under the control of the strong CO1A1 promoter.
What does that do?
It results in the tumor cells overproducing and secreting the PDGF growth factor. This secreted factor then stimulates the very same tumor cells, which express the PDGF receptor, in an autocrine loop, driving their proliferation and the tumor's growth. It's constantly telling itself to grow.
How is it treated?
The standard treatment is wide local excision. Often Mohs surgery is used to ensure clear margins because of its infiltrative growth pattern. For tumors that are unresectable or have metastasized, there are targeted therapies specifically, inhibitors of the PDGF receptor tyrosine kinase, like imatinib. These can be effective, but often require lifelong treatment as they control the disease rather than cure it.
What does DFSP look like?
Visually, it often starts as a firm plaque that slowly grows into a raised nodule or cluster of nodules, hence the name protuberans. It's commonly found on the trunk. The overlying skin might be stretched, reddish-brown, and may eventually ulcerate.
And microscopically?
Microscopically, you see densely packed, relatively uniform, spindle-shaped fibroblasts. A highly characteristic feature is their arrangement in a store form or cartwheel pattern. The cells radiate out from central points. Mitotic figures aren't usually very common in typical DFSP. Unlike dermatofibroma with its overlying epidermal hyperplasia, the epidermis over a DFSP is often thinned or even ulcerated. A key feature for surgeons and pathologists is its pattern of deep extension into the subcutaneous fat it infiltrates along the fibrous septa and a characteristic lace-like or honeycomb pattern. Getting clear margins on this deep infiltration is critical to prevent local recurrence.
Okay, let's talk about some fascinating disorders involving cells that don't necessarily start in the skin, but whose job involves migrating there or homing to the skin.
Exactly. Cells whose early forms or progenitors are destined for the cutaneous environment, or cells that are drawn there as part of a disease process. We'll look at two important examples here from the sources: a lymphoma and a mast cell disorder.
Starting with mycosis fungoides. Despite the name, this isn't a fungal infection, right?
Correct. The name is historical and confusing. Mycosis fungoides is actually the most common type of cutaneous T-cell lymphoma, or CTCL. So it's a type of blood cancer, specifically a lymphoma of mature skin-homing CD4 plus T helper cells.
Skin-homing T cells. So they like the skin.
Precisely. These malignant T cells have molecules on their surface, like CLA and certain chemokine receptors, that direct them specifically to the skin. The disease often remains localized to the skin for many years, even decades, before potentially evolving into a more systemic lymphoma involving lymph nodes and internal organs. It can affect people at any age, but is most common in those over 40.
What do the skin lesions look like?
They typically evolve through stages. It often starts on the trunk or buttocks as scaly, red-brown patches, which can look very much like eczema or psoriasis, making early diagnosis tricky. Over time, these can progress to become raised, thickened, infiltrated plaques, which may still resemble psoriasis but are firmer. Eventually, some patients develop distinct tumor nodules, which can sometimes look like mushrooms, hence the fungoids part of the name.
Does the stage matter?
Very much so. The prognosis is strongly related to the extent of skin involvement, percentage of body surface area, and whether the disease progresses from patch to plaque to tumor stage.
Can it become widespread?
Yes. In early stages, it can be subtle. As it progresses to plaques, they become more raised and indurated. The development of multiple nodules is usually a sign of disease progression and potential for systemic spread. Sometimes the nodules can ulcerate. There's also a distinct severe leukemic form called Sézary syndrome, where the malignant T cells circulate in the bloodstream and infiltrate the entire skin surface, causing widespread redness and scaling.
Erythroderma.
What's driving this? Any specific mutations? The cells driving this are clonal, meaning they all originated from a single abnormal T cell that has this predilection for the skin. While various genetic mutations and chromosomal abnormalities are found in the malignant cells, contributing to their growth and survival, none are specifically diagnostic or unique to mycosis fungoides across the board, unlike some other cancers. Diagnosis often relies on recognizing the clinical picture, the histology, and demonstrating the clonality of the T cells, EVA-Z, through T-cell receptor gene rearrangement studies.
How is it treated?
Treatment depends heavily on the stage. For early skin-limited disease, patch plaque stage, therapies directed at the skin are often used, like potent topical steroids, topical chemotherapy agents, or UV light therapy, phototherapy like PUVA or narrowband UVB. For more advanced disease, tumors, significant lymph node involvement, or Sézary syndrome, systemic therapies are usually required, including various forms of chemotherapy, targeted agents, or immunotherapy.
What's the key feature under the microscope?
The histologic hallmark, especially in the patch and plaque stages, is the presence of these atypical T cells forming a band-like infiltrate in the superficial dermis, right below the epidermis. Importantly, these malignant T cells show a tendency to migrate into the epidermis. This is called epidermotropism. They can be seen as single cells scattered within the epidermis or forming small clusters, which are known as Potrier microabscesses.
What do the cells look like?
The atypical T cells often have distinctive nuclei that look highly folded or convoluted, often described as cerebriform, brain-like. In patch and plaque stages, this epidermotropism is usually prominent. In the later nodular tumor stage, the malignant cells tend to lose this prominent epidermotropism, grow more densely as sheets in the dermis, and may spread systemically.
Okay. Next, mastocytosis. This sounds like it involves mast cells.
Exactly. This is a diverse spectrum of rare disorders characterized by an increased number of mast cells in the skin and sometimes other organs like the bone marrow, liver, spleen, and lymph nodes.
Is it mainly a skin problem?
The purely cutaneous form is most common, especially in children, accounting for over half the cases. It typically presents in one of two main ways. Urticaria pigmentosa, which consists of multiple small, round to oval, red-brown, non-scaling papules and small plaques, usually on the trunk. Or it can be a single lesion, usually in very young children, called a solitary mastocytoma, a pink to tan-brown nodule that might be itchy or even blister.
What about adults?
About 10% of cases, usually presenting in adults, involve systemic disease with mast cell infiltration in multiple organs. Systemic mastocytosis has a more guarded prognosis compared to the purely cutaneous forms.
What kind of symptoms do people get? Is it just the spots?
No, the symptoms are often due to the mast cells releasing their potent chemical mediators, histamine, heparin, proteases, cytokines, etc., either spontaneously or when triggered. A classic diagnostic sign is the Derrier sign. If you firmly rub one of the skin lesions, it becomes swollen, red, and itchy, forms a wheal, within minutes due to localized histamine release. Dermatographism, where stroking apparently normal skin causes a hive to form, is a similar phenomenon reflecting mast cell sensitivity.
Can releasing those chemicals cause wider problems?
Yes, in systemic mastocytosis, or even sometimes with extensive skin involvement, these mediators cause widespread symptoms. Patients might experience intense itching, pruritus, and flushing, often triggered by various things like certain foods, temperature changes, alcohol, or specific drugs like aspirin or opiates. They can also have symptoms like nasal congestion or rhinorrhea, gastrointestinal issues, or even bleeding problems due to heparin release. A significant issue in systemic disease can be bone pain or even pathologic fractures due to mast cell infiltration in the bone marrow, leading to osteoporosis or osteosclerosis. Bone pain can be a surprising clue, especially in premenopausal women or men where significant osteoporosis is less expected.
Is there a known cause for the mast cells increasing?
Yes, a major breakthrough was the discovery that many cases, particularly systemic mastocytosis in adults, have acquired activating point mutations in the KIT gene. KIT encodes a receptor tyrosine kinase that is crucial for mast cell growth, survival, and function. These mutations make the KIT receptor constantly active, driving the mast cell proliferation. Similar activating mutations in related receptors like PDGFR-alpha are sometimes involved.
Has that discovery led to better treatments?
Absolutely. This understanding led directly to the development of targeted therapies, KIT kinase inhibitors, which can block the abnormal signaling. These drugs can cause dramatic improvement and regression of disease, even in patients with advanced systemic mastocytosis.
How does it look under the microscope?
Microscopically, the number and distribution of mast cells can vary greatly depending on the specific type and lesion. In urticaria pigmentosa, or solitary mastocytoma, you might see just a subtle increase in mast cells around the superficial dermal blood vessels, or you might see large numbers of them filling the upper and mid-dermis. Sometimes there's associated fibrosis, edema, or an infiltrate of eosinophils. Mast cells can actually be tricky to spot on routine hematoxylin and eosin H&E stains, as they can resemble lymphocytes or histiocytes.
So how do pathologists identify them?
Special metachromatic stains like toluidine blue or Giemsa are often used. These stains bind to the heparin-rich granules within the mast cells, making them stain a different color, pupil or metachromatic, and thus easily visible. However, if the mast cells have recently degranulated, released their contents, the granules might be sparse, making them harder to see even with special stains. In those cases, or for definitive confirmation, immunohistochemical stains for specific mast cell markers, like mast cell tryptase or the KIT protein, CD117, are used to highlight the cells. Now let's look at disorders specifically impacting how the top layer of skin, the epidermis, matures and sheds its outer layer.
Okay, problems with skin turnover.
Exactly. The classic example here is ichthyosis. This isn't a single disease, but a group of mostly inherited conditions characterized by a buildup of keratin on the skin surface, leading to chronic excessive scaling and dryness that can resemble fish scales. Ichthys means fish in Greek.
Fish scales? Wow, are there different kinds?
Yes, there are several different subtypes inherited in different ways, autosomal, dominant, recessive, X-linked, with varying degrees of severity and appearance. Most forms are apparent at or soon after birth. It's important to know there are also acquired forms of ichthyosis, particularly ichthyosis vulgaris, which can develop later in life, sometimes in association with other underlying health issues, including certain lymphoid or visceral malignancies.
What's going wrong in the skin? Why does it get scaly?
The core problem in most forms is a defect in desquamation, the normal process, where the outermost skin cells, corneocytes, flatten, lose their attachments, and shed from the surface. Instead of shedding properly, they are retained, leading to the buildup of scale. For example, in X-linked ichthyosis, the underlying issue is a deficiency in an enzyme called steroid sulfatase. This deficiency leads to an accumulation of cholesterol sulfate in the stratum corneum, which seems to increase cell adhesion and prevent the scales from separating and shedding normally.
So the cells stick together too much.
Essentially, yes. That leads to the visible scale. Under the microscope, all forms of ichthyosis show this buildup of compacted stratum corneum, the outermost layer, which loses its normal, loose basket weave pattern seen in healthy skin. It looks thick and dense. There's usually little to no inflammation in the underlying epidermis or dermis in most inherited forms. The different subtypes are further classified based on features like the thickness of the epidermis and the stratum granulosum, the layer just below the stratum corneum, as well as the clinical appearance and distribution of the scaling.
Let's move into inflammatory dermatoses conditions, where inflammation is the primary driver of what you see on the skin. We can split these into acute and chronic.
Good way to think about it. Acute inflammatory dermatoses tend to pop up relatively quickly, last days or weeks, and are often characterized by infiltrates of inflammatory cells, fluid buildup, edema, and sometimes injury to blood vessels or skin cells. Chronic ones, as the name suggests, persist for months or years and often lead to changes in the skin surface, like thickening or abnormal scaling due to the ongoing inflammation.
Okay, starting with the acute ones. Urticaria or hives? Sounds common.
Extremely common. It's basically a localized burst of inflammation where mast cells in the skin release histamine and other vasoactive mediators. This makes the small blood vessels in the dermis leaky, increases microvascular hyperpermeability, causing fluid to accumulate, resulting in those characteristic itchy, swollen bumps or plaques called wheals.
Angioedema.
Angioedema is essentially the same process but occurring deeper in the dermis and subcutaneous fat, leading to more diffuse swelling, often affecting areas like the lips, eyelids, or even airways.
Who gets hives?
Anyone can get them, but they're particularly frequent in the 20-40 age group. A key feature is that the individual wheals are transient. They typically develop and fade within hours, almost always less than 24 hours. However, episodes of urticaria can last for days, weeks, or even become chronic, lasting for months or years. Areas of the body subject to pressure are often affected, pressure urticaria.
If they keep coming back, does it mean something serious?
Persistent episodes can sometimes be a sign of an underlying systemic disease, like certain autoimmune collagen vascular diseases or even Hodgkin lymphoma. But in the vast majority of chronic urticaria cases, an underlying cause is never identified, idiopathic.
What triggers the mast cells to release histamine?
The most common trigger is an antigen-induced release, usually involving IgE antibodies. This is classified as mast cell-dependent, IgE-dependent urticaria. It's basically a localized immediate hypersensitivity reaction, type I, triggered by exposure to allergens like pollens, foods, drugs like penicillin, or insect venom. The allergen binds to IgE already present on the surface of mast cells, causing them to degranulate.
Are there other ways to get hives?
Yes. You can also have mast cell-dependent, IgE-independent urticaria, where certain substances directly incite mast cells to degranulate without involving IgE. Examples include opiates, some antibiotics, and radiographic contrast media. Then there's mast cell-independent, IgE-independent urticaria, which is much less common. This involves mechanisms that directly increase vascular permeability, for example, exposure to certain chemicals or drugs like aspirin, or rare inherited conditions like hereditary angioneurotic edema, where a deficiency in C1 inhibitor leads to excessive complement activation and release of vasoactive substances.
What do hives look like under the microscope?
Visually, they range from small itchy papules to large, edematous, often pale-centered plaques that can merge together, confluence. Microscopically, the changes can actually be quite subtle. You typically see a sparse inflammatory infiltrate, mainly mononuclear cells with occasional neutrophils, concentrated around the small blood vessels, paravenular, in the superficial dermis. Eosinophils might be present but aren't always prominent. The most striking feature is the dermal edema. The collagen bundles in the dermis are widely separated by clear space, representing the fluid buildup that causes the visible swelling. The overlying epidermis is usually completely normal. The dermal lymphatic vessels may also be dilated.
Okay. Next, acute eczematous dermatitis. Eczema is a word people use a lot.
Yes, eczema literally means to boil over, reflecting the weeping or blistering nature often seen. It's an extremely common pattern of inflammatory reaction in the skin. It encompasses a wide range of conditions with different triggers but similar appearance, including allergic contact dermatitis, poison ivy is a classic example, atopic dermatitis, often just called eczema, drug-related eczema, photoeczematous dermatitis, triggered by UV light plus a substance, and primary irritant dermatitis, caused by direct damage from a harsh substance.
What causes it?
The causes are often broadly categorized as inside jobs versus outside jobs. Outside jobs involve contact with an external agent, like the allergen in poison ivy or an irritant chemical. Inside jobs involve internal factors, like a systemic reaction to an ingested drug or the underlying immune dysregulation seen in atopic dermatitis. Figuring out the specific trigger is key, as removing the offending substance is the most effective treatment. Topical steroids are widely used to block the inflammation, providing relief and interrupting flare-ups, but they don't cure the underlying sensitivity or cause.
What's the immune mechanism usually?
The core mechanism for many forms, especially allergic contact dermatitis, is a T-cell-mediated delayed type hypersensitivity reaction, type IV. Let's use poison ivy again. The oily chemical, urushiol, from the plant isn't allergenic by itself, but it binds to self-proteins in the skin, acting as a hapten and creating new antigens, neoantigens. Langerhans cells, the skin's antigen-presenting cells, pick these up, process them, and migrate to regional lymph nodes. There, they present the neoantigens to naive CD4 plus T cells, sensitizing them and generating effector and memory T cells.
So the first exposure primes the system.
Exactly. Then, upon re-exposure to poison ivy, these sensitized memory T cells, which have skin homing molecules, quickly migrate to the affected skin site. Within about 24 hours, they release cytokines and chemokines that recruit a host of other inflammatory cells, leading to the characteristic redness, itching, and blistering, the acute spongiotic phase of the reaction. Langerhans cells are really central to this process. Interestingly, UV light can sometimes damage Langerhans cells and prevent sensitization, but it can also alter antigens, potentially playing a role in photodermatitis.
You mentioned spongiosis. What's that?
Spongiosis is the characteristic histologic feature of acute eczema, so much so that acute eczematous dermatitis is often called spongiotic dermatitis microscopically. It refers to edema fluid seeping into the intercellular spaces within the epidermis, particularly the stratum spinosum. This fluid pushes the keratinocytes apart, making them look splayed like a sponge. If the edema is severe enough, the mechanical shearing forces can rupture the connections between cells, desmosomes, leading to the formation of intraepidermal vesicles or tiny blisters filled with this fluid.
What does acute eczema look like clinically?
It typically presents as red papulovesicular, meaning small bumps and small blisters, often oozing and crusted lesions. If it persists, it becomes subacute or chronic, leading to reactive thickening of the epidermis, acanthosis, and stratum corneum, hyperkeratosis, resulting in raised, scaling plaques that are less wet. Poison ivy is a striking example with its intensely itchy, red, swollen, edematous, oozing plaques often studded with blisters, sometimes in linear streaks where the plant brushed against the skin. These lesions are prone to bacterial superinfection, impetiginization, often by Staph aureus, which adds a characteristic yellowish crust.
And the very earliest microscopic changes.
Early on, before the full-blown spongiosis develops, you might see a superficial perivascular, around blood vessels, lymphocytic infiltrate in the upper dermis, papillary dermal edema, swelling in the finger-like projections of the dermis, and evidence of mast cell degranulation. The pattern and composition of the inflammatory infiltrate can sometimes offer clues to the cause. For example, ingested drug reactions often have prominent eosinophils in the infiltrate, whereas allergic contact dermatitis typically has a predominantly mononuclear infiltrate without many eosinophils, often concentrated more superficially.
Okay. What about erythema multiforme? That sounds different.
It is different. Erythema multiforme, EM, is an uncommon, usually self-limited hypersensitivity reaction that seems to be triggered primarily by certain infections or drugs. It can occur at any age.
What kind of infections or drugs?
Strong associations include infections like herpes simplex virus, a very common trigger for recurrent EM, mycoplasma pneumonia, and fungal infections like histoplasmosis or coccidioidomycosis, as well as bacterial infections like typhoid or leprosy. Associated drugs include sulfonamides, penicillin, barbiturates, salicylates, hydantoins, and antimalarials. It can also rarely be associated with underlying cancer or collagen vascular diseases.
What's the mechanism here? Still T cells.
Yes, the current thinking is that EM represents keratinocyte injury mediated by skin-homing CD8 plus cytotoxic T lymphocytes, CTLs. These CTLs recognize antigens, perhaps viral or drug-related antigens, expressed on the surface of epidermal cells and kill them. It appears to share a common pathogenic mechanism with other conditions involving CTL-mediated attack on keratinocytes, such as acute graft versus host disease, skin allograft rejection, and certain types of drug eruptions, like fixed drug eruptions. Histologically, CD8 plus T cells are prominent centrally within the lesions, while CD4 plus helper T cells and Langerhans cells are more peripheral. The specific epidermal antigens targeted are generally unknown.
Are there severe forms?
Yes, EM exists on a spectrum. Severe variants include Stevens-Johnson syndrome, SJS, which typically presents with fever and extensive blistering and sloughing of the skin and mucous membranes, mouth, eyes, genitals. SJS is often triggered by drugs and is more common in children. It can be life-threatening due to fluid loss and risk of secondary infection, sepsis. Toxic epidermal necrolysis, EEN, is considered the most severe end of the spectrum, characterized by diffuse necrosis and sloughing of the cutaneous and mucosal epithelium, resembling an extensive burn. SJS and TEN are now often considered variants of the same process, differing mainly in the extent of skin detachment.
What do the lesions look like in typical EM?
The name multiform means many forms, reflecting the diversity of lesions that can occur. These include macules, papules, vesicles, and bullae, larger blisters. However, the most characteristic lesion is the targetoid or target-like lesion. This typically has three zones: a dusky or blistered center, surrounded by a pale ring of edema, and an outer erythematous red ring. The distribution of lesions can also vary widely.
And the histology of those target lesions?
Microscopically, the characteristic targetoid lesions show a superficial perivascular lymphocytic infiltrate, associated dermal edema, and crucially, lymphocytes accumulating along the dermoepidermal junction. These lymphocytes are associated with degenerating or dying necrotic basal keratinocytes. This pattern of inflammation centered at the junction is termed interface dermatitis. You often see lymphocytes migrating upwards into the epidermis, exocytosis. Widespread death of epidermal cells, epidermal necrosis, can lead to the formation of blisters, usually subepidermal or involving the full thickness of the necrotic epidermis. Where the epidermis sloughs off completely, it leaves shallow erosions.
Moving into chronic inflammatory dermatoses, these are conditions that stick around for months or years, and the skin often gets rougher and thicker with abnormal scale.
Exactly. They represent persistent inflammation driving changes in epidermal structure and turnover.
A prime example is psoriasis. This is common, right?
Yes, a very common chronic inflammatory dermatosis, now understood to have an autoimmune basis. It affects about 1–2% of people in the U.S., can start at any age, but often peaks in early adulthood or later in life.
Does it just affect the skin?
Primarily skin and nails, but about 15% of people with psoriasis also develop an associated arthritis, known as psoriatic arthritis. This can range from mild to severe and deforming, affecting joints in patterns similar to or different from rheumatoid arthritis. Psoriasis is also associated with other conditions like myopathy and neuropathy, inflammatory bowel disease, and it's seen more frequently or severely in individuals with AIDS.
What causes psoriasis? Is it purely genetic?
It's a complex interplay between genetic susceptibility, certain HLA variants are strongly associated, and environmental factors or triggers. The precise initiating antigens remain elusive, but the key players in established lesions are immune cells, sensitized CD4 plus T helper cells, particularly Th1 and Th17 subtypes, and activated CD8 plus cytotoxic T cells infiltrate the skin and accumulate in the epidermis.
What do these T cells do?
They create a pro-inflammatory microenvironment by releasing a potent cytokine soup, including key players like IL-12, interferon gamma from Th1 cells, TNF, tumor necrosis factor, and IL-17 from Th17 cells. These cytokines act on keratinocytes, stimulating them to proliferate excessively and mature abnormally, leading to the thickened, scaly lesions. The importance of these cytokines is highlighted by the remarkable effectiveness of biologic drugs that specifically target TNF or the IL-17-IL-23 axis in treating psoriasis. The infiltrating lymphocytes also produce keratinocyte growth factors, further contributing to the epidermal thickening acanthosis.
What about the Koebner phenomenon?
That's a classic feature of psoriasis. It refers to the appearance of new psoriatic lesions at sites of skin injury or trauma, like a scratch or surgical wound. This suggests that local injury can trigger or set in motion the self-perpetuating local inflammatory response that drives lesion formation.
What does psoriasis look like clinically?
The most frequent sites are the elbows, knees, scalp, lumbosacral area, lower back, the intergluteal cleft, and the glans penis. The typical lesion is a well-demarcated, pink to salmon-colored plaque covered by characteristic, loosely adherent silvery white scales. The appearance can vary, sometimes forming ring-like annular shapes or covering large areas. Widespread involvement of the entire body surface with redness and scaling is called erythrodermic psoriasis. Nail changes are common, affecting about 30% of patients, and can include yellow-brown discoloration, oil slick appearance, pitting, dimpling, separation of the nail plate from the bed, onycholysis, thickening and crumbling.
And the microscopic picture.
Established psoriatic lesions have several characteristic histologic features. There's marked epidermal thickening, acanthosis, with regular downward elongation of the rete ridges, which are often described as looking like test tubes in a rack because they are club-shaped and uniform. Mitotic figures, dividing cells, are seen well above the basal layer, reflecting the increased proliferation. The stratum granulosum, the granular layer just below the stratum corneum, is typically thin or absent, and there's extensive overlying parakeratotic scale. The stratum corneum is thickened and retains nuclei.
What about the blood vessels?
Another key feature is the thinning of the epidermal layer directly over the tips of the dermal papillae, the upward projections of the dermis. These dermal papillae contain dilated, tortuous blood vessels that are very close to the surface. This proximity explains the Auspitz sign, the appearance of minute bleeding points when the silvery scale is lifted or scraped off, as those superficial capillaries are easily injured. Finally, neutrophils, another type of inflammatory cell, are characteristically present, often forming small aggregates in the superficial epidermis, spongiform pustules, or within the parakeratotic stratum corneum, Monroe microabscesses. In pustular psoriasis, these neutrophil collections become much larger, forming visible pustules.
Okay. What about seborrheic dermatitis? Is that related to psoriasis?
Not directly related, but it's another very common chronic inflammatory condition, even more common than psoriasis, affecting perhaps 5% of the U.S. population. It classically involves regions with a high density of sebaceous glands, like the scalp, forehead, especially eyebrows and glabella, external ears, nasolabial folds, and the presternal area, mid-chest. Importantly, despite the name and location, it's primarily an inflammation of the epidermis, not primarily a disease of the sebaceous glands themselves.
So the name is misleading.
A bit, yes. The precise etiology is still unknown. While increased sebum production, which is influenced by androgens, might be a contributing factor, for instance, it's often seen in patients with Parkinson's disease who can have increased sebum. Other conditions with increased sebum, like acne, aren't associated with seborrheic dermatitis. So sebum seems necessary but not sufficient. A relationship with Malassezia species, yeasts that are part of the normal skin flora, has long been suggested, as antifungal treatments can help, but definitive proof of a causal role is lacking. Interestingly, A particularly severe form of seborrheic dermatitis is seen in individuals with advanced HIV infection, low CD4 counts, and its incidence fell dramatically with the advent of effective antiviral therapy, suggesting an immune component is important.
What does it look like? Is it just dandruff?
Dandruff is considered the mildest and most common expression, limited to the scalp. More generally, seborrheic dermatitis presents as macules and papules on an erythematous red and often yellowish, greasy base, typically associated with extensive scaling and crusting. Fissures can occur, especially behind the ears.
And the histology?
Microscopically, seborrheic dermatitis can share features with both spongiotic dermatitis, like acute eczema, and psoriasis. And the appearance can vary depending on the stage. Early lesions might show more spongiosis, while chronic lesions become more acanthotic, thickened epidermis, sometimes with parakeratosis similar to psoriasis. A relatively characteristic finding, though not always present, is the presence of mounds of parakeratosis containing neutrophils and serum, particularly situated at the ostia openings of hair follicles, sometimes called follicular lipping. There's usually a superficial paravascular inflammatory infiltrate in the dermis composed of lymphocytes and neutrophils.
Lichen planus next. I remember the 6PS description.
Yes, that's the classic mnemonic. Pruritic, itchy, purple violaceous color, polygonal angular shape, planar, flat-topped, papules and plaques. It's a disorder of the skin and mucous membranes.
Does it go away?
Cutaneous lesions are usually self-limited, typically resolving spontaneously over 1 to 2 years, although they often leave behind persistent brown marks, post-inflammatory hyperpigmentation, especially in darker skin types. Oral lesions, however, can persist for years and be more problematic.
Any long-term risks?
Yes, squamous cell carcinoma sometimes arises within chronic erosive lesions of oral or genital lichen planus, suggesting that the chronic inflammation might foster carcinogenesis in susceptible individuals. Like psoriasis, lichen planus can also exhibit the Koebner phenomenon, with new lesions appearing at sites of trauma.
What's the cause here? Autoimmune again?
The exact cause and antigens are not known, but it's widely believed to be a T-cell mediated autoimmune process where cytotoxic CD8 plus T cells attack basal epidermal keratinocytes. It's thought that perhaps antigens within these basal cells or at the dermo-epidermal junction become altered somehow, triggering this targeted immune response.
What does the lesions look like? You mentioned purple papules.
Yes, cutaneous lesions are typically itchy, violaceous, purplish, flat-topped papules, often only a few millimeters in diameter initially, but they can coalesce to form larger plaques. A characteristic feature, often visible with magnification like a dermatoscope, or sometimes just barely with the naked eye, are fine white dots or lines on the surface of the papules or plaques. These are called Wickham striae and correspond histologically to focal areas of thickening of the granular layer, hypergranulosis. On darker skin, the purple color might be less obvious, and the lesions may appear dark brown, especially as they resolve due to melanin release into the dermis. They are usually multiple and often symmetrically distributed, favoring the extremities, especially the wrists and elbows and the glans penis. Oral mucosal lesions are very common, present in up to 70% of cases, and typically appear as white, lacy, reticulated net-like patterns on the inside of the cheeks, buccal mucosa, but can also be erosive and painful.
And the histology was a defining pattern.
Microscopically, the hallmark of lichen planus is a dense, continuous, band-like infiltrate of lymphocytes along the dermo-epidermal junction. It's considered a prototypic example of an interface dermatitis. These lymphocytes are intimately associated with basal keratinocytes, which often show signs of damage, degeneration, or death, necrosis or apoptosis, sometimes referred to as vacuolar alteration or liquefactive degeneration of the basal cell layer. Because of this damage at the junction, the dermo-epidermal interface often loses its normal smooth curve and develops an angulated zigzag configuration, often described as sawtoothing. Enucleate necrotic basal cells may drop into the papillary dermis and become incorporated into eosinophilic pink globules called colloid bodies or civat bodies. In addition to these interface changes, you usually see evidence of chronicity, such as epidermal hyperplasia, acanthosis, though sometimes the epidermis can be atrophic, hypergranulosis, thickened granular layer corresponding to Wickham striae, and hyperkeratosis, thickened stratum corneum.
So to summarize these chronic inflammatory conditions,
Many specific types exist, often driven by T-cell mediated immune responses, targeting skin components, like in psoriasis and lichen planus, or involving complex interactions with skin flora and sebum, like seborrheic dermatitis. Diagnosis relies heavily on correlating the clinical appearance, distribution, and morphology of lesions with the characteristic microscopic patterns of inflammation and epidermal changes, like the interface pattern in lichen planus or the specific acanthosis and paracarotote pattern in psoriasis.
Let's talk about blistering or bullous diseases. As the name implies, blisters are the main feature here, right?
Exactly. These conditions are defined by the presence of blisters, bully or just large blisters. They can range from merely annoying to dramatic and sometimes even fatal if extensive or untreated. The key concept is that blisters form because of a loss of adhesion between cells, causing the layers of the skin to separate and fluid to collect in the resulting space.
Does it matter where the split happens?
Critically important. Blisters can occur at different levels. Within the epidermis itself, intraepidermal, or between the epidermis and the dermis, subepidermal. Identifying the precise level of the split by examining a biopsy under the microscope is essential for diagnosis and also provides crucial insights into the underlying pathogenesis or cause of the blistering. Figure 25.27 in your sources nicely illustrates these different levels.
And what causes the layers to separate?
Often these diseases are caused by acquired autoantibodies or inherited defects targeting the proteins that are responsible for holding skin cells together, like components of desmosomes, intercellular glue, or for anchoring the epidermis to the underlying basement membrane and dermis, like components of hemidesmos, the anchors. Figure 25.28 shows some of these key structural proteins.
Okay, let's break them down. Inflammatory blistering disorders first.
Right. Pemphigus is a major group here. It's a blistering disorder caused by autoantibodies, the patient's own immune system making antibodies against components of desmosomes. This leads to the dissolution of those intercellular attachments within the epidermis or mucosal epithelium.
Who gets pemphigus?
It typically affects adults, often in the 4th to 6th decades of life, with roughly equal incidence in men and women. There are several variants, including pemphigus vulgaris, pemphigus vegetans, pemphigus foliaceus, pemphigus erythematosus, and a rare paraneoplastic pemphigus associated with underlying cancers. While historically potentially fatal if untreated, most forms are now manageable with immunosuppressive therapy.
Tell us about the common types. Pemphigus vulgaris.
Pemphigus vulgaris, PV, is the most common type, accounting for over 80% of cases worldwide. It affects both mucous membranes, especially the mouth, and the skin. Often painful oral ulcers or erosions are the first sign and may precede skin blisters by weeks or months. The skin lesions are typically superficial vesicles and bullae that rupture very easily because their roof is thin, leaving behind widespread, denuded, painful erosions that are slow to heal.
And pemphigus foliaceus.
Pemphigus foliaceus, PF, is generally a more benign superficial form. There's an endemic form in Brazil known as fogo selvagem, wildfire. PF typically affects the scalp, face, chest, and back, but mucous membranes are rarely involved. Because the blisters form very high up in the epidermis, they are extremely fragile and often rupture almost immediately. So clinically, patients often present mainly with erythema, redness, and crusting from the ruptured blisters, rather than intact bullae. Pemphigus erythematosus is considered a localized, less severe variant of PF, often affecting the face in a pattern resembling lupus. Paraneoplastic pemphigus is associated with underlying malignancies, most commonly non-Hodgkin lymphoma, and involves autoantibodies against multiple adhesion proteins.
So what's the core mechanism? Autoantibodies against desmosomes.
Exactly. All forms of pemphigus are autoimmune diseases caused by IgG autoantibodies directed against desmogleins. Desmogleins, DSG1 and DSG3, are transmembrane glycoproteins that are crucial components of desmosomes, responsible for cell-to-cell adhesion in the epidermis. When these autoantibodies bind to desmogleins, they disrupt intercellular adhesion. A key diagnostic test is direct immunofluorescence, DIF, on a skin biopsy, which shows deposition of IgG and often complement component C3 in a characteristic net-like or chicken wire pattern outlining the epidermal cells, reflecting the location of desmosomes.
Does the specific target explain the different types?
Yes, largely. The level of the blister split and the clinical presentation depend on which desmoglein is primarily targeted. In Pemphigus vulgaris, the autoantibodies predominantly target DSG3, which is mainly expressed in the deeper layers of the epidermis and mucous membranes, and sometimes also DSG1. This leads to blisters forming deeper within the epidermis, just above the basal cell layer, suprabasal split, and explains the frequent mucosal involvement. In Pemphigus foliaceus, the autoantibodies primarily target DSG1, which is mainly expressed in the superficial layers of the epidermis. This causes a very superficial split, typically within the stratum granulosum, and explains why mucous membranes, which mainly rely on DSG3, are usually spared. These antibodies are thought to directly interfere with desmisome function and may also activate intracellular signaling pathways or proteases that further break down cell adhesion.
How does pemphigus look under the microscope?
The common histologic feature linking all types of pemphigus is acantholysis, that dissolution of the intercellular bridges connecting keratinocytes. This causes the epidermal cells to detach from each other, round up, and float freely within the blister cavity. These are called acantholytic cells. In pemphigus vulgaris and its variant pemphigus vegetans, the acantholysis occurs selectively just above the basal cell layer, resulting in a suprabasal blister. The intact basal cells remain attached to the basement membrane, often lining the floor of the blister like a row of tombstones. Pemphigus vegetans also shows marked overlying epidermal hyperplasia, creating the wart-like clinical appearance. In Pemphigus foliaceus, the acantholysis and blister split occur much more superficially, usually within or just beneath the stratum granulosum. In all types, there's usually a variable dermal inflammatory infiltrate containing lymphocytes, macrophages, and often eosinophils. Treatment aims to suppress the immune system, example with corticosteroids and other immunosuppressants, to reduce the production of these pathogenic autoantibodies.
Okay, what about bullous pemphigoid? Similar name, different disease?
Similar name, but a distinct autoimmune blistering disease. Bullous pemphigoid, BP, typically affects older individuals, usually over 60. It presents with a wider clinical range than pemphigus, often involving tense blisters on the skin, sometimes preceded by itchy, hive-like plaques, urticarial lesions.
Where do the blisters usually appear?
Common sites include the inner aspects of the thighs, flexor surfaces of the forearms, axillae, groin, and lower abdomen. Oral lesions can occur but are much less common than in Pemphigus vulgaris, maybe 10–15% of cases, and usually appear after the skin lesions. Severe itching, pruritus, is a very common symptom, sometimes even before blisters appear.
How are the blisters different from pemphigus?
Morphologically, the blisters in BP are typically tense bullae, filled with clear fluid arising on either erythematous, red, or normal-appearing skin. They are usually less than 2 centimeters in diameter but can be larger. Importantly, they do not rupture as easily as pemphigus blisters because their roof consists of the full thickness of the epidermis. They often heal without scarring unless they become secondarily infected. Microscopically, the key difference from pemphigus is that the blister forms below the entire epidermis, it's a subepidermal blister, and there is no acantholysis within the epidermis itself.
What causes the split below the epidermis in BP?
BP is caused by autoantibodies that bind to proteins required for the adherence of basal keratinocytes to the underlying basement membrane. These proteins are components of hemidesmosomes, the structures that anchor the basal cells. Direct immunofluorescence, DIF, in BP shows a characteristic continuous linear deposition of IgG and/or complement C3 along the dermoepidermal junction, the basement membrane zone.
Which proteins are targeted?
The main target antigens in BP are two components of the hemidesmosome, historically called bullous pemphigoid antigens 1 and 2, BPAK1 and BPAG2, now also known as BP230 and BP180 type X7 collagen, respectively. Antibodies against BPAG2, BP180, seem to be particularly important in causing the blistering. It's thought that binding of these autoantibodies to the hemidesmosome activates the complement cascade, which recruits inflammatory cells like neutrophils and eosinophils to the basement membrane zone. These inflammatory cells release proteases and reactive oxygen species that damage the hemidemosomes and disrupt the attachment of the epidermis, leading to the subepidermal split and blister formation.
And the histology reflects that.
Yes. Early urticarial lesions might just show a superficial and deep perivascular infiltrate with lymphocytes, numerous eosinophils, and some neutrophils, along with dermal edema. Developing blisters show vacuolization, small spaces, forming along the basal cell layer. Eventually, the damaged basal layer lifts off the basement membrane entirely, creating the clean subepidermal blister. Eosinophils are often characteristically numerous within the blister cavity and in the underlying dermis.
Okay, one more inflammatory one. Dermatitis herpetiformis. Sounds like herpes.
The name is another historical misnomer. It has nothing to do with the herpes virus. Dermatitis herpetiformis, DH, is a rare autoimmune blistering disease characterized by intensely itchy pruritic urticaria hives and grouped vesicles, small blisters, often described as herpetiform because they cluster together like herpes lesions can.
Who gets DH?
It predominantly affects males, typically presenting in the 3rd and 4th decades of life, though it can occur at any age. The crucial association is with intestinal celiac disease, gluten-sensitive enteropathy. Virtually all patients with DH have associated celiac disease, although the gut symptoms might be mild or absent.
That link to celiac disease is key.
Absolutely. It provides the clue to pathogenesis. It's thought that in genetically predisposed individuals, strong association with HLA-DQ2 and HLA-DQ8, consuming dietary gluten, specifically the gliadin component, triggers the production of IgA antibodies. These IgA antibodies appear to cross-react with components of the skin, specifically with reticulin, a component of the anchoring fibrils that tether the epidermal basement membrane to the underlying papillary dermis. Deposition of these IgA antibodies at the tips of the dermal papillae triggers inflammation, particularly recruitment of neutrophils, and injury, leading to the formation of subepidermal blisters.
Does diet help?
Yes, both the skin condition, DH, and the associated gut condition, celiac disease, typically respond very well to a strict gluten-free diet, although the skin lesions may take longer to clear than the gut symptoms and sometimes require additional medication initially, like dapsone.
Where do the lesions appear?
DH lesions are characteristically bilateral, symmetric, and grouped. They favor the extensor surfaces, especially the elbows, knees, upper back, and buttocks. The itching is often severe. Microscopically, the earliest change is the accumulation of fibrin and neutrophils right at the tips of the dermal papillae, forming microabscesses. This inflammation causes vacuolization of the overlying basal cells and eventually separation of the epidermis from the dermis at these papillary tips. These small separations then coalesce to form the subepidermal blister.
And immunofluorescence.
Direct immunofluorescence, DIF, is diagnostic for DH. It shows characteristic discontinuous granular deposits of IgA, selectively localized within the dermal papillae tips, mirroring where the neutrophils accumulate.
Okay, let's switch to non-inflammatory blistering disorders. These aren't autoimmune.
Correct. These are generally mediated by inherited defects in structural proteins that are essential for maintaining the mechanical integrity of the skin, or sometimes by acquired metabolic issues.
Like epidermolysis bullosa.
Yes, epidermolysis bullosa, EB, is the major category here. It's not a single disease, but a blanket term for a group of inherited disorders, all characterized by defects in structural proteins needed for mechanical stability of the skin. The common feature is the formation of blisters at sites of pressure, rubbing, or minor trauma, often presenting at or soon after birth. Diagnosis involves careful clinical evaluation, biopsy for determining the level of skin cleavage, often requiring electron microscopy or specialized immunofluorescence antigen mapping, and genetic testing to identify the specific mutated gene.
How are the types classified?
EB is broadly classified based on the level at which the skin separation occurs, which corresponds to the location of the defective protein. The simplex types involve defects within the basal cell layer of the epidermis itself, most commonly due to mutations in the genes for keratin 5 or keratin 14, KRT5, KRT14, which form intermediate filaments within these cells. These are usually inherited in an autosomal dominant fashion. This is the most common form group. The junctional types show blister formation within the lamina lucida, a layer within the basement membrane zone itself. These are typically autosomal recessive and often caused by defects in proteins that bridge the hemidesmosome to the basement membrane, like subunits of laminin 332, or sometimes mutations in BPA2, type 7 collagen. The dystrophic types involve blister formation below the lamina densa, the main layer of the basement membrane, due to rudimentary or defective anchoring fibrils. Anchoring fibrils normally secure the basement membrane to the underlying dermis. These forms are caused by mutations in the COL7A1 gene, which encodes type 7 collagen, the major component of anchoring fibrils. Dystrophic EB can be inherited as either autosomal, dominant, or recessive, with the recessive forms generally being more severe and associated with significant scarring. There are also mixed types recognized, like Kindler syndrome, with defects in multiple adhesion structures.
Okay. And porphyria. That sounds metabolic.
It is. Porphyria refers to a group of uncommon inherited or sometimes acquired disturbances in the metabolic pathway for synthesizing porphyrins. Porphyrins are essential pigment molecules that form the core of heme, which is vital for hemoglobin, myoglobin, and cytochromes. Defects in specific enzymes in this pathway lead to accumulation of different porphyrin precursors.
How did that cause skin problems?
5 major types of porphyria are recognized, and several of them have cutaneous manifestations. These typically include urticaria, hives, and the formation of vesicles and bullae, particularly in sun-exposed areas, often associated with skin fragility and scarring upon healing. The blisters are subepidermal. Histologically, a characteristic finding in the adjacent dermis is the presence of vessels with thickened, glassy-appearing walls due to deposition of serum proteins, including immunoglobulins and complement. The exact pathogenesis linking the porphyrin abnormalities to the skin fragility, photosensitivity, and blistering is complex and not fully understood for all types, but involves light absorption by the porphyrins generating reactive oxygen species that damage skin structures.
Let's quickly recap these blistering disorders.
Okay. Classified by the level of epidermal separation. Inflammatory ones are often caused by autoantibodies attacking epithelial adhesion proteins, desmosomes, or basement membrane anchoring proteins, hemidesmosomes anchoring fibrils.
Pemphigus, IgG autoantibodies to desmogleins, intraepidermal blisters, subcorneal and foliaceous, suprabasilar and vulgaris.
Bullous pemphigoid. IgG autoantibodies to hemidesmosome proteins, BPEGs.
Subepidermal blister.
Dermatitis herpetiformis. IgA autoantibodies related to gluten sensitivity, targeting anchoring fibrils, subepidermal blisters with neutrophils and papillae.
Non-inflammatory ones, inherited defects in skin-stabilizing structural proteins, like keratins, laminin, tight collagen, and epidermolysis bullosa, or metabolic defects in porphyrin synthesis, porphyrias, leading to photosensitivity and blistering.
Moving on to disorders affecting the skin appendages, primarily hair follicles and sebaceous glands. We'll focus on two extremely common ones, acne and rosacea.
Right, conditions many listeners will be familiar with.
Acne vulgaris, you said, virtually universal in teens. Pretty much. It affects most adolescents to some degree during puberty, though severity varies greatly. It tends to be more severe in males. It's seen in all races, though sometimes reported as milder in individuals of Asian descent. It can also be induced or exacerbated by certain drugs like corticosteroids or lithium, occupational exposures like oils or tars, or conditions causing occlusion of the skin like heavy cosmetics or helmets. There's definitely a hereditary component influencing susceptibility and severity too.
What are the different kinds of spots? Comedones.
Acne lesions are broadly divided into non-inflammatory types, comedones, and inflammatory types, papules, pustules, nodules, cysts. Open comedones are blackheads. These are follicular papules containing a central plug of keratin and lipid, which appears black due to oxidized melanin, not dirt. Closed comedones are whiteheads. These are similar follicular papules, but the opening to the surface is obstructed, so the keratin plug isn't visible and remains trapped beneath the surface. These are often the precursors to inflammatory lesions because the trapped material can lead to follicle rupture and inflammation.
What causes acne? It seems complex.
It is definitely multifactorial, involving the interplay of several key factors within the pilosebaceous unit, the hair follicle and its associated sebaceous gland. 1. Abnormal keratinization of the lower part of the follicular infundibulum, the funnel-shaped opening. This leads to the formation of a keratin plug, microcomedo, that blocks the outflow of sebum. 2. Hypertrophy of sebaceous glands and increased sebum production, primarily driven by androgens, male hormones, during puberty in both sexes. 3. Colonization of the follicle by the bacterium Propionibacterium acnes, now renamed Cutibacterium acnes. This bacterium is part of the normal skin flora that thrives in the lipid-rich environment of the follicle. It produces enzymes, lipases, that break down sebum lipids into free fatty acids, which are pro-inflammatory. 4. Secondary inflammation of the follicle, triggered by the trapped sebum, bacterial byproducts, and the body's immune response to them. If the follicle wall ruptures, this inflammation spills into the surrounding dermis.
The androgen link seems important.
Yes, the link to androgens explains the onset at puberty, and was noted long ago. For example, young males who were castrated before puberty didn't develop acne. Treatment strategies target these different pathogenic factors. For example, topical retinoids help normalize follicular keratinization. Antibiotics, topical or oral, aim to reduce the population of C. acnes and also have direct anti-inflammatory effects. For severe recalcitrant acne, isotretinoin, a synthetic oral retinoid derived from vitamin A, is highly effective, primarily through its strong inhibitory effect on sebaceous gland size and function, significantly reducing sebum production.
What does inflammatory acne look like?
It ranges from erythematous, red papules and pustules, pus-filled bumps, to deeper, tender nodules and fluctuant cysts. Severe nodulous cystic acne, sometimes called acne conglobata, can involve interconnected sinus tracts and lead to significant dermal scarring. Microscopically, depending on the stage and type of lesion, you see the comedones, open or closed, with dilated follicles filled with keratin and sebum. In inflammatory lesions, there's a variable infiltrate of lymphocytes and macrophages surrounding the follicles. When follicles rupture, you see extensive acute inflammation, neutrophils extending into the dermis, sometimes forming dermal abscesses, which ultimately heal with scarring.
Okay. What about rosacea? Is that just adult acne?
It's often mistaken for acne, especially the papulopustular form, but it's a distinct chronic inflammatory condition, typically affecting adults, usually middle-aged and older, with a predilection for females, affecting perhaps 3% of the U.S. population.
Does it progress in stages?
Yes. Rosacea is often described as progressing through 4 stages, though not everyone goes through all of them. 1. Flushing episodes, pre-rosacea. Transient facial redness triggered by various stimuli like heat, alcohol, spicy foods. 2. Persistent erythema and telangiectasias. Constant facial redness, particularly on the cheeks, nose, forehead, and chin, with visible small blood vessels. 3. Papules and pustules. Superimposed bumps and pus-filled lesions resembling acne but typically without comedones, blackheads, whiteheads. 4. Rhinophyma. Primarily in men, this is characterized by permanent thickening of the skin of the nose, with prominent pores, papules, and follicular plugging, due to marked sebaceous gland hypertrophy and fibrosis.
What causes rosacea? Is it understood now?
The exact pathogenesis is still being unraveled, but recent research points towards dysregulation of the innate immune system in the skin. Patients with rosacea seem to have abnormally high cutaneous levels of an antimicrobial peptide called cathelicidin. Furthermore, the form of cathelicidin peptides found in rosacea skin appears to be different, abnormally processed by proteases like kallikrein 5, and more pro-inflammatory than those found in normal skin. Injecting these specific peptides into mice induces changes resembling rosacea, including inflammation and vascular dilation.
What triggers this abnormal peptide?
It seems related to increased activation of certain receptors, like toll-like receptor 2, TLR2, on keratinocytes, which then upregulates the production of the protease, kallikrein 5, that processes cathelicidin abnormally. What initially stimulates TLR2 is still debated. Potential triggers like microbes, e.g. Demodex, mites, or bacteria have been proposed, but their definitive role remains unproven. It's likely a complex interaction between genetic predisposition, immune dysregulation, environmental triggers, and possibly the neurovascular system.
What does it look like microscopically?
The histology varies with the stage. In the erythematous telangiectatic stage, you might see nonspecific parafollicular inflammation, mostly lymphocytes, dermal edema, and prominent dilation of superficial blood vessels, telangiectasias. In the papulopustular phase, neutrophils may colonize the hair follicles, sometimes leading to follicle rupture and a secondary granulomatous inflammatory response in the dermis, parafollicular granulomas. In rhinophyma, the most striking feature is marked hypertrophy, enlargement, of sebaceous glands, along with follicular plugging by keratotic debris and fibrosis, scarring in the dermis.
Shifting gears slightly to panniculitis, this involves the fat layer.
Yes, panniculitis isn't a single disease, but rather refers to an inflammatory reaction occurring in the subcutaneous adipose tissue, the fat layer located below the dermis. Panniculitis can primarily affect the fatty lobules themselves, lobular panniculitis, or the fibrous connective tissue septa that divide the fat lobules, septal panniculitis. It often presents as tender nodules, commonly on the lower legs.
What's the most common type?
The most common form is erythema nodosum, EN. This typically presents as a subacute eruption of poorly defined, tender, erythematous red plaques and nodules, which are often more easily felt, palpated, as deep, firm bumps than clearly seen visually. They commonly occur on the shins.
Is it caused by something specific?
EN is considered a hypersensitivity reaction and is associated with a wide variety of underlying conditions. These include infections, especially streptococcal infections, tuberculosis, and deep fungal infections like coccidioidomycosis or histoplasmosis, also leprosy, certain drugs like sulfonamides and oral contraceptives, systemic inflammatory diseases like sarcoidosis and inflammatory bowel disease, and occasionally underlying malignancies. However, in a significant number of cases, no specific underlying cause is ever found, idiopathic EN. Patients might also experience systemic symptoms like fever, malaise, and joint pain.
How is it thought to happen?
The pathogenesis is thought to involve a delayed type hypersensitivity reaction to microbial or drug antigens, possibly involving deposition of immune complexes in some cases, but the exact mechanism remains mysterious for many cases.
Does it leave scars?
No, EN typically resolves over several weeks. The lesions gradually flatten, often undergoing bruise-like color changes, erythema contusiformis, and heal without ulceration or scarring, although new lesions can continue to develop during an episode. Diagnosis usually requires a deep wedge biopsy that includes the subcutaneous fat layer to identify the characteristic septal inflammation.
What does the biopsy show?
Microscopically, EN is the classic example of a mostly septal panniculitis. In early lesions, the connective tissue septa between the fat lobules are widened by edema, fibrin exudation, and an infiltrate of neutrophils. Later, the infiltrate evolves to include lymphocytes, histiocytes, multinucleated giant cells, and sometimes eosinophils, accompanied by septal fibrosis. A key distinguishing feature is that the blood vessels within the septa are generally not inflamed. Vasculitis is typically absent in EN.
What's another type? Erythema induratum.
Erythema induratum is an uncommon form of panniculitis, primarily affecting adolescents and menopausal women. Its exact cause is also often unknown, but it's now generally regarded as representing a primary vasculitis, inflammation of blood vessels, involving the deep vessels that supply the fat lobules. This vascular compromise is thought to lead to subsequent fat necrosis and inflammation.
How does it present?
It typically presents as erythematous, slightly tender nodules, often on the posterior calves, which have a tendency to ulcerate, unlike erythema nodosum. Historically, erythema induratum, also called Bayesian disease when linked to TB, was considered a hypersensitivity reaction to tuberculosis, but now it often occurs in individuals without any evidence of underlying TB or other diseases.
And the microscopic picture here.
Microscopically, erythema induratum is characterized as a mostly lobular panniculitis with caseous cheese-like necrosis of the fat lobules and associated granulomatous inflammation. Importantly, early lesions often show evidence of necrotizing vasculitis involving small to medium-sized arteries and veins located deep in the dermis or within the septa of the subcutaneous fat.
Are there other kinds of panniculitis?
Yes, there are many other types, though less common. Examples mentioned include Weber-Christian disease, a historical term for relapsing febrile nodular panniculitis, which is lobular and non-vasculitic, featuring foamy macrophages; factitial panniculitis, caused by self-inflicted injury or injection of foreign substances; rare forms of T-cell lymphoma that's specifically home to the fat lobules and can mimic panniculitis clinically and histologically; and panniculitis associated with systemic diseases like systemic lupus erythematosus or pancreatic disease. Distinguishing these often requires careful clinical correlation and sometimes specialized tests.
Finally, let's acknowledge the skin's vulnerability to infection, despite all its protective functions.
Absolutely. We touched on bacteria in acne earlier. Viral infections causing skin lesions are numerous, like herpes, chickenpox, shingles, measles, as are fungal infections. And infections can be much more severe or unusual if the host's immune system is compromised. We'll just highlight a few common infections with primary skin manifestations from your sources.
Okay, starting with verrucae, or warts. Everyone knows warts.
Indeed. Verrucae are common, benign, squamoproliferative lesions caused by infection of epidermal keratinocytes with human papillomaviruses, HPVs. They are most frequent in children and adolescents, but can occur at any age. Transmission occurs through direct contact with an infected individual or contaminated surfaces, and autoinoculation, spreading to other sites on the same person, is common. While they can be persistent and annoying, most warts are generally self-limited and regress spontaneously without treatment over a period of 6 months to 2 years, likely due to the development of cell-mediated immunity against the virus-infected cells.
Are all warts caused by the same virus?
No, there are over 150 different types of HPV identified. Different clinical variants of warts are often linked to specific HPV types. For example, common warts, Verruca vulgaris, are often caused by HPV types 2 and 4. Plantar warts on the soles of the feet by HPV type 1, flat warts, Verruca plana, by types 3 and 10. Anogenital warts, condylomata acuminata, are usually caused by low-risk HPV types 6 and 11.
You mentioned HPV and cancerous before.
Yes, certain high-risk HPV types, particularly HPV 16 and 18, are strongly linked to squamous cell carcinoma, especially in the anogenital region, cervix, vulva, penis, anus. HPV 16 can also cause a condition called bohinoid papulosis, which presents as multiple genital papules that histologically look like carcinoma in situ, but usually regress spontaneously. Interestingly, as mentioned with SCC, HPV types 5 and 8 are linked to SCC development in the rare genetic condition epidermodysplasia verruciformis, but their E6 oncoproteins work differently from high-risk types. They don't efficiently degrade p53, possibly explaining their lower oncogenic potential in the general population. Low-risk HPVs, like those causing common warts, possess E6 proteins that can interfere with Notch signaling, which is required for normal keratinocyte maturation, and this likely contributes to the epidermal hyperplasia seen in warts. Viral typing can be done using techniques like in situ hybridization or PCR if needed, but usually isn't necessary for common warts.
What do common warts look like?
Verruca vulgaris, the most common type, typically occurs on the hands, particularly the backs, dorsum, and around the nails, periungual. They present as gray-white to tan, flat-topped, planar to elevated papillomatous papules, often with a rough, pebble-like or filiform, finger-like surface. Tiny thrombosed capillaries may be visible as black dots within the wart.
And the histology.
Microscopically, warts show characteristic features including papillomatous epidermal hyperplasia, undulating thickening of the epidermis, hyperkeratosis, thickened stratum corneum, and parakeratosis, retained nuclei in the stratum corneum. A key diagnostic feature is the presence of cytopathic alterations in the superficial epidermal layers caused by the HPV infection. These include nuclear pallor and enlargement, and prominent irregular keratohyaline granules in the cytoplasm cells showing these changes are called koilocytes, although classic koilocytes are more typical of general HPV infections.
Okay. Molluscum contagiosum, another virus.
Yes, molluscum contagiosum is another common self-limited viral disease of the skin caused by infection with a pox virus, specifically molluscum contagiosum virus, MCV. The virus particle itself is quite distinct. It's large, around 300 millimeters, brick-shaped, with a dumbbell-shaped DNA core, making it one of the largest pathogenic viruses known.
How do you get it?
Infection is spread by direct contact, including sexual contact in adults, or via contaminated fomites, like towels. It's very common in children, especially those with atopic dermatitis, and also seen in young adults and immunocompromised individuals, where lesions can be much larger and more numerous.
Impetigo. That sounds bacterial.
It is. Impetigo is a common superficial bacterial infection of the skin, highly contagious, particularly among children, though adults in poor health or crowded conditions can also be affected. It typically occurs on exposed skin areas like the face, especially around the nose and mouth, and hand.
And the bacteria cause it.
There are two main clinical forms, non-bullous, impetigo contagiosa, and bullous impetigo, differing mainly by the size of the pustules or blisters. Historically, impetigo contagiosa was primarily caused by group A hemolytic streptococci, while bullous impetigo was caused by Staphylococcus aureus. However, there's been a shift, and now S. aureus is the most common cause of both forms, although strep can still be involved, sometimes co-infecting with staph.
How does it cause the skin lesions?
The bacteria colonize the superficial layers of the epidermis, triggering an innate immune response, recruiting neutrophils and causing epidermal injury. This leads to the accumulation of local serous exudate, which dries to form the characteristic scale crust or scab. Blister formation, particularly in bullous impetigo, is caused by specific exfoliative toxins produced by certain strains of S. aureus. These toxins specifically cleave desmoglein-1 eta DSG1, the same cell adhesion protein targeted by autoantibodies in pemphigus foliaceus. This cleavage disrupts cell adhesion in the uppermost epidermal layers, subcorneal split, leading to blister formation. Because the infection and the resulting split are very superficial, impetigo typically heals without scarring once the bacteria are eliminated by the immune response or antibiotics.
What does it look like when it starts?
It usually presents initially as small erythematous maculas, red spots, but multiple small pustules rapidly supervene. These pustules are fragile and quickly break, leaving shallow erosions covered by a thick, adherent yellowish or honey-colored crust, which is very characteristic of non-bullous impetigo. In bullous impetigo, larger, flaccid blisters, bullae, are the predominant feature.
Your sources also mention superficial fungal infections.
Yes, they are mentioned as another common category of skin infection, like Tinea pedis, athlete's foot, Tinea corporis, ringworm, Tinea cruvis, jock itch, or Tinea capitis, scalp ringworm, caused by the modified fungi that live in the keratinized layer of the skin, hair, or nails. Candida infections are also common. However, the provided source material doesn't go into specific detail on their morphology or pathogenesis in this section.
Right, a huge and common group, but not detailed in these specific sources we're diving deep into today.
Correct. We've stuck closely to the material provided.
We have covered a huge amount of ground today, really diving deep into your sources to understand the skin's unexpected roles beyond just being a barrier, the intricate details of its cells and structures, the wide spectrum of conditions from benign spots like freckles and moles all the way to aggressive cancers like melanoma, and the complex inflammatory responses like psoriasis or blistering diseases like pemphigus, plus infections.
It's a massive topic, and we've hit on so many key concepts: senescence in moles, the ABCDEs of melanoma, interface dermatitis, acantholysis, spongiosis. The list goes on.
You see how seemingly simple things like freckles differ fundamentally from lentigines based on melanocyte numbers, how moles have that built-in stop signal, sinus cancers often lose, and how understanding complex diseases like psoriasis or pemphigus reveals fundamental aspects of skin biology and immune function. We even touched on how understanding the genetics and immune responses, like the hedgehog pathway in BCC, or the T-cell roles in psoriasis and melanoma, is leading to truly revolutionary targeted treatments.
It's remarkable how much detail and how many different biological processes, immunology, genetics, cell biology, metabolism, are packed into this single organ, and how much we can learn about overall health and disease by understanding it properly.
So what does mastering this information, really getting into the weeds like we did today, mean for you? Well, beyond being incredibly well informed, you now have a much deeper appreciation for your body's largest organ and the amazing science behind its health and disease. You can look at skin conditions, whether on yourself or hearing about them, with a new level of understanding, hopefully seeing the patterns and the underlying mechanisms we discussed.
It gives you the vocabulary and the conceptual framework to engage with this topic on a much more professional level, understanding the why behind the what, just like the dermatologists and pathologists who specialize in this field strive to do.
So here's where it gets really interesting and maybe a provocative thought for you to consider as we wrap up. Given the deep connections we explored today between the skin and systemic diseases, genetics, the immune system, even things like your gut microbiome or hormonal status potentially playing roles, what does the skin truly reveal about your overall health?
That's a big question.
Are there connections we discussed today, maybe the link between acanthosis nigricans and diabetes, or certain adnexal tumors and internal cancer syndromes, or even just the way stress might flare up eczema or psoriasis that make you think differently about a seemingly simple rash or mole? What other internal signals might your skin be showing you, perhaps subtly, just waiting to be interpreted or better understood?
A fascinating area for sure, connecting the outside to the inside. There's likely still so much more to discover about those links.
Keep exploring, keep observing your own skin and the world around you, and definitely keep asking questions.